This is a Dr. Ho, California Formulary webinar from December 13, 2017. It's going to start in about 2 minutes, hopefully.
Administrative Director for the California Department of Industrial Relations, Division of Workers' Compensation. Welcome to the Division's educational webinar on the Medical Treatment Utilization Schedule Drug Formulary. We will be presenting a repeat of this webinar tomorrow at 2 o'clock, and in addition, we'll be posting the slides and recorded webinar on the Division's website for later viewing. Let me introduce Dr. Raymond Meister is the Executive Medical Director of the Division of Workers' Compensation. Jacqueline Schauer is an attorney in the DWC Legal Unit and has been working on the Formulary rulemaking action. Lucy Shannon is with the Reed Group and is the Director of Editorial Research and Development. The Reed Group is the publisher of the American College of Occupational and Environmental Medicine Guidelines. American College is also known as ACOM. Today, we will be providing some information regarding the legislative background to the new Workers' Compensation Drug Formulary, and we'll explain how it fits within the larger framework of the Medical Treatment Utilization Schedule. Dr. Meister and Jackie Schauer will discuss the details of the MTUS drug list and ancillary formulary rules. We are happy to have Lucy Shannon of the Reed Group here to demonstrate the very useful features of the online ACOM treatment guideline and formulary tools. AB 1124, which was signed by Governor Brown on October 6, 2015, requires that the division adopt an evidence-based drug formulary as part of the medical treatment utilization schedule. The MTUS drug formulary is the result of many months of study, consultation with the public, and formal rulemaking to receive public comment. It is important to note that the drug formulary is part of the MTUS. The drug formulary and the MTUS treatment guidelines work together to guide treatment decisions. We are pleased that effective December 1st, 2017, the division has adopted updated treatment guidelines of the American College of Occupational and Environmental Medicine. Dr. Meister will provide an overview of the MTUS and the recent evidence-based updates to the guidelines, which provide the backbone to the drug formulary. Last month, the division presented a webinar focused on the MTUS updates, which is available for viewing on the DWC website. Although some of the material today overlaps with the MTUS webinar, please bear with us as the formulary is an integral part of the MTUS and successful implementation is founded upon use of the MTUS treatment guidelines and the MTUS rules. Now, Dr. Meister will provide an overview of the MTUS.
Thanks, George, and good morning, everyone. What is the MTUS? When most people think of the MTUS, they think of medical treatment guidelines. But it is more than that. It is a set of regulations that provide the clinician with an analytical framework for the evaluation and treatment of injured workers in the California Workers' Compensation System. It is found within the California Code of Regulations, Title 8, beginning at Section 9792.20. As of January 1st, 2018, the MTUS will also include the regulations section application of evidence-based medicine through use of the ACOM guidelines is intended to improve patient care. For conditions not covered by the guidelines, or if a guideline recommendation is being challenged, the MTUS is important because it sets forth a scientifically sound method of evaluating medical evidence. The MTUS is important because it is the primary source of guidance for treating physicians and physician reviewers in the California workers' compensation system. The MTUS provides the pathway to providing appropriate patient care and getting As of December 1st of this year, the DWC incorporated by reference the most recent American College of Occupational and Environmental Medicine medical treatment guidelines into the MTUS. The new treatment guidelines are effective for all medical services rendered on or after December 1st, 2017. At the end of this presentation is a resources slide with a link to a webpage where you can find the Administrative Director's order, which includes the regulatory amendments. Let's look at how the MTUS regulation adopting a medical evidence search sequence guides evidence. This flow chart graphic illustrates the medical evidence search sequence mandate to always begin by searching in the adopted MTUS guidelines. Now that the DWC has adopted the most recent ACOM guidelines, the patient's injury or condition will most likely be addressed in the ACOM guidelines adopted into the MTUS. Take a look at the yellow flow chart on the right-hand side of the slide. Ask yourself, is the patient's condition or injury addressed by an MTUS guideline? If the answer is yes, then ask yourself, does the recommendation found in the MTUS guideline support the treatment request or treatment plan? If the care the doctor wishes to provide is supported by the MTUS guidelines, then simply apply the MTUS guideline recommendation to the treatment of your patient. There's no mystery to this. In fact, it can be a very simple process. However, let me emphasize, without proper documentation, your request for authorization or RFA can still be denied even if you followed this process. Proper documentation is the key to approval. Before we turn to the use of recommendations found outside of the MTUS guidelines, take a look at the second blue box which states, search in the most current ACOM guidelines or official disability guidelines. You may ask yourself, why would I need to search the most current ACOM guidelines when I already did that in step 1, the top blue box? Here's the difference. An ACOM guideline is not yet part of the MTUS until the DWC formally adopts it. Currently, all of the MTUS guidelines are. However, there may be ACOM guidelines that have not been adopted into the MTUS. For example, the traumatic brain injury guideline was just published by ACOM, but the DWC has not yet adopted the ACOM traumatic brain injury guideline into the MTUS. Until we do so, the traumatic brain injury guideline is not considered an MTUS guideline. Okay, now turn to the use of recommendations found outside of the MTUS guidelines for patient treatment. Here is a slide that shows the medical evidence search sequence again, but this time the treating provider is searching for treatment recommendations outside of the MTUS guidelines. There are only 2 limited situations that may warrant treatment based on recommendations found outside of the MTUS guidelines. Take a look at the red box on the right-hand side. The first situation is when the patient's medical condition is not addressed in the MTUS guidelines. The physician should continue through the search sequence to find evidence-based approaches to care. The second situation is when the patient's medical condition is addressed in the MTUS guidelines, but the recommendations do not support the physician's desired treatment plan. Recommendations found in the MTUS guidelines are presumed correct. So, if the doctor disagrees with these recommendations, he or she may challenge them by finding recommendations outside of the MTUS that are supported treating physician bears the burden of proving the medical necessity of treatment requests when challenging the adopted treatment guidelines. In both situations, the physician will need to find recommendations outside of the MPUS guidelines that support the treatment plan. In order for the treatment plan to be approved, the recommendation must be supported by the best available evidence. You may be wondering why this webinar on the formulary is discussing the MPUS treatment guidelines in such depth. It's important to understand that the MPUS formulary is a component of the medical treatment utilization schedule. The regulations define the MPUS drug formulary to include the MPUS drug list and formulary rules. In addition, the formulary rules make it clear that the MPUS regulations, including the medical evidence search sequence and the MPUS methodology for evaluating medical evidence, are applicable to determine the medical necessity of pharmaceutical treatment. We can think of the MPUS drug formulary as having three essential parts: the ACOM treatment guidelines, which are the backbone of the formulary; the MPUS drug list, which guides prospective review requirements; and the ancillary formulary rules. The MPUS drug list is not a standalone document. It must be used in conjunction with the adopted ACOM treatment guidelines, which are presumed correct on the scope of medical treatment. For conditions not covered by the MPUS guidelines, or if the physician challenges the treatment recommendation in the MPUS guidelines, the MPUS medical evidence search sequence illustrated in the previous slide is applicable and guides the selection of evidence-based pharmaceutical treatment. The MPUS drug formulary regulations were approved by the Office of Administrative Law and filed with the Secretary of State on December 7, 2017. The regulations become effective on January 1st, 2018. The MPUS drug formulary will apply to drugs dispensed on or after January 1st, 2018, regardless of the date of injury. However, for injured workers who are receiving an ongoing course of treatment with a non-exempt drug, an unlisted drug, or a compounded drug, there is a regulation addressing the physician's duty to submit an updated treatment plan so that there is a phased implementation of the formulary as guided by the newly adopted ACOM treatment guidelines. MPUS drug formulary applies to drugs dispensed for outpatient use at home or outside of a clinical setting. The MPUS drug formulary does not apply to physician-administered drugs. However, it should be noted that physician-administered drugs are often subject to the ACOM treatment guidelines adopted into the MPUS. For example, recommendations for the use of steroid injections into a joint. Now let's examine the MPUS drug list, which is adopted into the formulary regulations. This slide shows the first page of the drug list. The list is posted on the DWC website in PDF and Excel formats. At the top of the MPUS drug list is a condensed narrative overview of ancillary formulary rules such as the physician dispensing rule, generic versus brand rule, and special fill and perioperative policies. Looking at the headings, we can see that the MPUS drug list is organized by active drug ingredient, lists a reference brand for most of the drugs, designates the exempt or non-exempt status for each drug, designates drugs which are eligible for the special fill and perioperative fill by including a number of days supply entry. The drug class is listed. The reference and guidelines column lists ACOM treatment guidelines adopted into the MPUS that address the drug, and each entry includes a symbol to indicate the type of ACOM recommendations that are in each guideline. We will discuss this column in greater detail shortly. The last three columns with the headings dosage form, strength, unique pharmaceutical pharmaceutical identifier, currently do not have data. They are reserved for future use, and the division intends to consult with the Pharmacy and Therapeutics Committee on using these columns to enhance the usefulness of the drug list. All of the drugs contained in the MPUS drug list are drugs that are addressed by the ACOM treatment guidelines that have been adopted into the MPUS. The MPUS drug list is not a standalone document and must be used in conjunction with the ACOM treatment guidelines adopted into the MPUS. Later in this presentation, Lucy Shannon of the READ Group will be demonstrating the ACOM guidelines and formulary tool and will explain how to obtain a license from the READ Group. Next, we will examine some important features of the MPUS drug list in greater depth. To assist in the provision of timely care and with a focus on the critical acute phase of treatment, we have designated certain medications as exempt drugs on the MPUS. Criteria considered in designating a drug as exempt are listed on this slide. In short, exempt drugs are those that are generally safe and effective in the treatment of the acute phase of common work-related injuries and illnesses. Exempt drug status should be of benefit to providers and their patients in that these medications will be provided to the injured worker with no prospective review as long as they are ordered in accord with the recommendations of the MPUS treatment guidelines. However, the physician dispensing rule and brand name rule need to be consulted for drugs otherwise designated as exempt. Let me note here that there may certainly be situations where a non-exempt drug will be appropriate and supported by the guidelines. Now let's take a deeper look at the reference in guidelines column. This column indicates which ACOM guidelines address the drug. Taking the example of acetaminophen, we see that 10 different guidelines address the medical evidence for use of acetaminophen. The reference in guideline column cannot be used on its own. It must be used in conjunction with the underlying ACOM guideline adopted into the MPUS. This column is intended to be a quick reference for which guideline topics should be consulted for a particular disorder or condition. The legend for the symbols is set forth in the narrative information at the top of the MPUS drug list. We have enlarged them here. These symbols indicate which types of evidence-based recommendations are contained in each guideline. Recommended means that the drug has sufficient evidence-based support to use the drug for one or more conditions in the guideline. Not recommended means that the medical evidence is sufficient to have a recommendation against use of the drug for one or more conditions in the guideline. And no recommendation if there is not sufficient evidence or recommendation for or against the use covered in the guideline. But again, you have to go to the applicable guideline and review the entire recommendation to properly use a medication on the MPUS drug list. Let's look at the example of the entry for acetaminophen on the MPUS drug list. It is listed as exempt. This means it is exempt from prospective utilization review as long as its use is consistent with the ACOM guideline adopted into the MPUS. The reference in guideline column shows that 10 guidelines have evidence-based recommendations for use of acetaminophen. Each guideline addresses many types of conditions or injuries, and acetaminophen may have evidence of benefit for some, but not all of the conditions. If we look at the elbow disorders guideline, we would see that many conditions are covered, including ulnar neuropathy at the elbow. Based on the evidence reviews, conditions, the guidelines contain recommendations on whether to use acetaminophen to treat the conditions, which may depend on the phase of care. Let's look at a few screenshots from the MD Guidelines website to illustrate some of these points. you would see if you searched for the use of acetaminophen within the elbow disorders chapter for the condition of ulnar neuropathy at the elbow. This screenshot shows that there are times that acetaminophen is recommended and other times that it is not recommended for the treatment associated with the same condition. In this slide, I have expanded the information available on the yes recommendation, and you might note that there are comments for both the prescriber and the claims professional here. In the final shot, I have provided the actual ACOM treatment guideline recommendations regarding acetaminophen use in ulnar neuropathy at the elbow. And again, this is what the healthcare provider would ultimately rely on. Now let's take a look at what the designation of non-exempt means. In short, non-exempt drugs are those medications that are generally used in the chronic phase of care or have more risk associated with their use or are used for less common work-related injuries and illnesses. Drugs listed as non-exempt are covered in the ACOM treatment guidelines, and users may obtain guidance and recommendations there. Let me emphasize that this formulary does not deny access to any FDA-approved drug. All non-exempt and any unlisted medications are available if medically necessary and approved through the usual prospective review process. Let me also note here that there may certainly be situations where a non-exempt drug will be appropriate for the patient and supported by the guidelines. I'd like to spend a few minutes talking about opioid medications. All of us have probably seen these disturbing headlines which have been so prevalent over the last several years. Let me show you a screenshot from the ACOM opioids treatment guideline. This is the recommendation on the use of opioids for acute pain. Let me zoom in on the last paragraph of this recommendation. Let me read this from the ACOM opioid guideline. Long-term opioid use often begins with treatment of acute pain. When opioids are used for acute pain, clinicians should prescribe the lowest effective dose of immediate release opioids and should prescribe no greater quantity than needed for the expected duration of pain severe enough to require opioids. 3 days or less will often be sufficient. More than 7 days will rarely be needed. As noted in the ACOM guideline quoted here, the Centers for Disease Control, or CDC, has found that 3 days or less of opioid use is often sufficient. The CDC recommendation I mentioned on the previous slide was published in 2016. In 2017, the CDC released new findings as noted on this slide. They found that in patients being treated for acute pain who were not previously using opioids, that the risk of still being on opioids a year later started increasing with the 3rd day of opioid use, with a sharp increase noted on the 5th day. In light of these findings and consistent with opioid use recommendations, the MTUS formulary allows the urgent provision of appropriate opioids for severe acute pain without prospective review, but limits the supply to a maximum of 4 days unless authorization is obtained. This special fill provision of the MTUS formulary will be discussed in more detail later in this webinar. And for that discussion and additional information on the MTUS formulary rules, I'll now turn the presentation over to my DWC colleague, Jackie Schaaf.
Thank you, Dr. Meister. I'm going to be discussing some of the ancillary rules that work together in conjunction with the MTUS guidelines and the MTUS drug list. First, we will look at the rule regarding the use of brand name and generic drugs. Both brand name drugs and generic drugs are available to treat the injured worker. Labor Code Section 4600.1 currently requires that a generic be dispensed unless the physician specifies the brand name must be dispensed. As of January 1, 2018, The formulary regulation will govern the issue of generic versus brand instead of Labor Code Section 4600.1. The formulary regulations adopt the preference for generic drugs, where the brand name drug is more expensive than the generic equivalent. A doctor can write a prescription for a brand name drug and specify that it must be dispensed as written or no substitution allowed. However, if there is a less costly therapeutic equivalent, the doctor must substantiate the medical necessity of the more costly brand name drug, including the patient-specific factors that support the need for the brand that could not be met by the generic therapeutic equivalent. The determination of whether the brand and generic are therapeutic equivalents is based upon the Food and Drug Administration's determination that the two drugs are assigned a therapeutic equivalence evaluation code beginning with the letter A. These therapeutic equivalence codes are set forth in the FDA's publication called the Orange Book. The formulary regulations adopt a special policy we call special fill. Under this policy, designated non-exempt drugs may be dispensed without prospective review if they meet the criteria. In order to be eligible for the special fill, the drug must be designated as special fill eligible on the MTS drug list. The drug must be prescribed at a single initial treatment visit, and that visit must occur within 7 days of date of injury. The supply of the drug must not exceed the number of days supply listed on the MTS drug list, and the drug dispensed must be the generic drug if a generic version exists and is less expensive than the brand name drug. However, where the doctor prescribes a more expensive brand name drug and indicates that no substitutions are allowed, he or she must document the medical necessity for the brand name drug rather than the generic drug. The doctor must specify patient-specific factors to support the medical necessity for the brand name drug. Let's look at a snip of the MTS drug list showing the entry for baclofen, a muscle relaxant. We can see that it is designated as a special fill drug by looking at the special fill column of the MTS drug list. The special fill column indicates that a 4-day supply of baclofen is eligible for special fill. The reference guidelines column indicates which ACOM treatment guidelines adopted into the MTS address baclofen. We can see that 5 of the guidelines have yes recommendations for use of baclofen. The physician will need to review the relevant guidelines to determine the recommendations for use of baclofen in light of the patient's specific condition. The MD Guidelines ACOM Formulary tool will allow users to search by drug name, see recommendations for use of the drug by condition, pain severity, and phase of care. The Excel format of the MTS drug is useful as it can be sorted by the various columns so that someone wanting to see all of the special fill eligible drugs can easily sort the document by that field. The special fill drugs include selected muscle relaxants, corticosteroids, and opioid analgesics. These drugs have a higher risk profile than many other medications, but may be urgently needed and therefore will not require prospective authorization when the special fill criteria are met. Currently, all of the special fill drugs are specified for a 4-day supply. If the patient needs a longer course of treatment, the physician should obtain authorization, which can be requested on an expedited basis if expedited review is warranted by the injured worker's condition. The perioperative fill policy adopted in the formulary regulations is similar to the special fill policy and covers designated non-exempt drugs. In order to be eligible for the perioperative fill, the drug must meet the following criteria. The drug must be designated as perioperative fill eligible on the MTS drug list. The drug must be prescribed during the perioperative period, which the regulations define 4 days before surgery to 4 days after surgery. The supply of the drug must not exceed the number of days supply listed on the MTS drug list. The drug dispensed must be the generic drug if the generic version exists and is less expensive than the brand name drug. However, where the doctor prescribes a more expensive brand name drug and indicates that no substitutions are allowed, he or she must document the medical necessity of the brand name drug. of the MQS drug list showing the entry for warfarin sodium, an anticoagulant. We can see that it is designated as a perioperative fill drug by looking at the perioperative fill column of the MQS drug list. The perioperative fill column indicates that it is a 14-day supply of warfarin sodium eligible for perioperative fill. Referencing guidelines column indicates which ACOM treatment guidelines adopted into the MQS address use of warfarin sodium. We can see that 3 of the ACOM guidelines address use of warfarin sodium. The hip and groin disorders guideline and the knee disorders guideline both contain 1 or more recommendations supporting use of the drug. The physician will need to consult the guidelines to determine which conditions are addressed and the detailed recommendations for use. The Read Group's Formulary tool will allow users to search by drug name, see recommendations for use of the drug by condition, pain severity, and phase of care. The Excel format of the drug list is useful as it can be sorted by the various columns so that someone wanting to see all the perioperative fill eligible drugs is easily sorted by that field. The perioperative fill drugs include selected anticoagulants, opioid analgesics, muscle relaxant, and an anticonvulsant. Where a surgery is scheduled and is not performed on an emergency basis, the physician should obtain prospective authorization for the surgery and for the related medication. However, the perioperative fill is available to provide medications where needed for appropriate care. For example, there may be an unexpected need for perioperative medication or a need to change medication if a patient has an adverse reaction to a previously authorized drug. One of the ancillary formulary rules governs the physician dispensing pharmaceuticals. The division is aware that physician dispensing can be convenient to the patient and recognizes that the Business and Professions Code allows the doctor to dispense drugs to patients for conditions the doctor is treating. However, research has shown that physician dispensing may sometimes be influenced by financial incentives. In order to strike a balance between patient convenience and assuring our authorization through prospective review before dispensing by a physician of a drug except as set forth in the regulation. There are 3 exceptions to the requirement for prospective review before the physician dispenses the drug. First, exempt drugs may be dispensed without prospective review if the drug is dispensed at the initial visit and is dispensed within 7 days of the date of injury. Use of the drug must be in accordance with the MQS treatment guidelines. The second and third exceptions are where the physician is dispensing the drug under the special fill policy or the perioperative fill policy. Another important part of the regulation is the provision that recognizes that physician dispensing may be restricted pursuant to a medical provider network agreement or a pharmacy benefit contract, Labor Code Section 4642. In workers' compensation, the employer is required to provide reasonable and necessary medical treatment to cure or relieve the employee of effects of the injury. For pharmaceutical treatment, this can be done through pharmacy-dispensed medication. The formulary regulations require that a compounded drug be authorized through prospective review before it is dispensed to the injured worker. In order to obtain authorization, the physician must document the medical necessity and include patient-specific factors that require use of a compounded medication instead of a drug approved by the United States Food and Drug Administration. Some examples of situations that may warrant use of a compounded drug are a patient with an allergy to a dye or filler contained in the FDA-approved drug, or a patient who cannot swallow a pill and needs a liquid form of a drug that is not available in that dosage form in FDA-approved product. The FDA approval process is intended to ensure safety and efficacy of drugs. Compounded drugs do not go through an FDA approval process. Assembly Bill 1124 directed the division to provide guidance regarding how an injured worker may access off-label use of prescription drugs when evidence-based and medically necessary. By tying the off-label use into the treatment guidelines and the usual MQS method for supporting treatment outside of the guidelines. What is off-label use? The formulary regulations have a definition, which states that off-label use means use of a drug for a condition or in a dosage or method of administration not listed in the drug's FDA-approved labeling for approved use. Since the express legislative intent is that the off-label use is evidence-based and medically necessary, regulations provide that off-label use of exempt medications do not require prospective review if the off-label use is supported by the MQS treatment guidelines. For non-exempt drugs or unlisted drugs, off-label use requires prospective review, and the medical necessity will be governed by the usual rules, including the MQS evidence search sequence, the quality and strength of evidence definition, and the methodology for evaluating the medical evidence. There are several other regulatory provisions that we would like to discuss briefly. One of the regulations is entitled Waiver of Prospective Review. This section provides that prospective review may be waived where a utilization review plan adopts a prior authorization program pursuant to the UR regulation in section 9792.7, subdivision A5. Another regulation section clarifies that the drug formulary does not relieve the employer of obligations to provide treatment under the California Health and Safety Regulations, such as Cal-OSHA bloodborne pathogen standard. Another formulary regulation states the DWC may maintain and post a listing of the MQS drug list by National Drug Code, RxCY, maintained by the National Library of Medicine, or other unique pharmaceutical identifier. The division will be considering the usefulness of adopting such a list and intends to seek input from the Pharmacy and Therapeutics Committee. The regulations specify that updates to the MQS drug list will be made at least quarterly and will be adopted by an administrative director order, which will be posted to the division's webpage. The formulary regulations also address the composition, role, and function of the Pharmacy and Therapeutics Committee. There will be quarterly meetings open to the public, chaired by the DWC Medical Director. The role of the P&T Committee is to provide advice to the Administrative Director on updates to the formulary. The P&T Committee will be composed of 3 physicians, medical doctors, and doctors of osteopathy are eligible, and 3 pharmacists. DWC is now accepting applications to serve on the committee. An application form to use and a conflict of interest disclosure form are posted on the DWC website. Now we will look at an important regulation relating to transition plans. Assembly Bill 1124 specifies that there should be a phased implementation of injuries prior to the effective date of the formulary. This is accomplished by adopting a rule that specifically addresses workers injured before January 1, 2018, who are on an ongoing course of drug treatment. We want to emphasize that the adoption of the formulary does not mean that all injured workers need to be transitioned to exempt drugs. The non-exempt drug, or an unlisted drug, or a compounded drug could be appropriate for the injured worker's condition. It is important that the treating physician review the injured worker's treatment plan, looking at the guidance and the applicable adopted ACOM treatment guidelines, or consider other evidence-based guidelines or studies if the condition is not covered in the ACOM guidelines. The formulary regulations refer to the usual reporting format to present the physician's treatment plan, which is the progress report, or PR2, required by Section 9785 of the regulations. Doctors are required by Section 9785 to submit a PR2 no less frequently than every 45 days during ongoing treatment. Ideally, the physician will submit the transition plan along with the RFA at the next PR2 due date. If that is not feasible, the regulations allow the report, treatment plan, and request for authorization to be submitted by April 1, 2018. This slide contains information on obtaining a license from the READ Group for commercial users of the ACOM guidelines and formulary and the MQS drug list. READ Group is offering a special discounted price for new California medical provider subscribers. The web page link is set forth on the slide. Persons and entities who are not medical providers should contact Joe Guerriero of the REIT Group to obtain a license. His contact information and phone number are also on the slide and on our website. Now, I am pleased to introduce Lucy Shannon, Director of Editorial Research and Development of the REIT Group. She will demonstrate use of the ACOM guidelines and the Formulary tool.
Thank you, Jackie. It'll take just a moment for us to trade screens here so that I can take you into a demo of the site. So bear with me while we make that changeover. Jackie, could you just verify that you are seeing the homepage of the MD Guidelines website?
Yes, we are.
Thank you. I appreciate that. This is the website and the landing page that our users will see when they log into the MD Guidelines website. So as Jackie mentioned, this website does require a subscription. Once users are in the website, there's a number of different ways to access the clinical guidelines that are the basis for the MTUS. And I'm just going to go over here on the right-hand side of my screen is a Resources tab. And when I click on that, the second option that I have available is the ACOM Practice Guidelines. But you'll see directly below that is an entry for state guidelines. So users of MTUS have a couple different ways to go. They can go into the ACOM Practice Guidelines because they are the same as MTUS, or if users want to avoid any kind of confusion, if they click on the state guidelines, they're going to see that the first entry here is California MTUS. And when I click on that, all of the guidelines that have been adopted and went into effect on December 1st are available to users here. There's also an archive of the older guidelines if anyone needs to access those. So the first thing that I'm going to show you is how to navigate into the guidelines themselves. And for today's demonstration purposes, I am going to be focusing on looking at medications within these full-length guidelines. So I'm going to go ahead and go into the Handress and Forum Disorders Guideline. And the first choice that I have available to me here is a summary of recommendations. When a user clicks on the summary of recommendations, they're taken to a table of all of the recommendations that are available in this guideline. So lots and lots. You can continue to scroll down through this. Users can also do a Control F on this page. So if they know that there's something really specific that they're looking for, as you start to type in, and for me, my text box, when I do a Control F on my screen, is my upper right-hand corner. This is where my cursor is right now. So I started to type in NSAIDs. And it immediately took me to the entries for NSAIDs on this web page. So we can see that there's a number of different recommendations depending on what condition is being treated. So again, lots and lots of different entries. And all of these will take the user into information or the specific place in the guideline where this information is being displayed. So, for example, if I'm treating carpal tunnel syndrome, I can get there. If I'm, looking for tarsal tunnel syndrome, whatever that is, I can go ahead and navigate to that area of the guidelines themselves. When I click on it, here I am. I'm in the full-length guideline now, and the breadcrumbs that are being displayed across the top of the page help me to understand where I am in the guideline. So in this case, I am in the Handress and Forum guideline. I'm in the treatment recommendations for carpal tunnel syndrome, and I'm in the medications category. So again, I'm going to use these breadcrumbs to back myself up, and I'm going to go back and look at that initial table of contents that we had. So this, again, the summary of recommendations, is access to a table of all of the recommendations and the links that are available there. Take the user right into the place in the guidelines where that recommendation is located. But I'm also going to show you how to navigate into the guidelines without using the summary of recommendations table. So in this case, I'm interested in medication. It's a treatment. So I would go ahead and go down to the treatment recommendations. I was looking at information for carpal tunnel syndrome. And again, I'm specifically interested in the medications category. So again, I have the breadcrumbs across the top of my page that tell me where I am in the guideline. So this is just another way for users to be able to access this information. So we have other tools. So if a user wants to quickly access the recommendations that are in the guidelines without having to go and navigate through the entire guideline, we do have a tool called DART. DART stands for Diagnosis and Related Treatments. DART is available on this global toolbar that persists on the website regardless of where I am. So it doesn't matter what topic I'm looking at or what disorder guideline, these tools are always going to stay available to me. When I click on the DART tool, I'm taken to the page where I can enter information about the condition that's being treated. So again, the recommendations that are available in DART are only coming from the ACOM guidelines. When I get to this tool, I do need to indicate the condition that's being treated. So I can go ahead and start to type carpal tunnel syndrome, and I'm able to go ahead and click on that. And then I can use the filters that are available here to get into the recommendations themselves. So category is another drop down, and all of these categories have recommendations for carpal tunnel syndrome. Had I been looking at a different topic, then this list of categories may look a little bit different. I don't have to make a selection. So if I am looking for a recommendation and I don't know exactly what category to navigate to, I don't actually have to make a selection. So I could leave it as any. But again, today we